Hi and welcome to this webinar where I'm going to be going through some of the general overriding themes that should be running through our management of some of the more persistent presentations that we will tend to see in limbs, and that's going to be tendinopathy. Okay, so I'm not going to be going into specific management of individual tendons in this program, but the general themes that should run through all of them. And then at the end, I will finish with guidance on research that provide a framework for specific load management. And I have other presentations guiding with videos around that. And straight off the bat, I want to be able to guide anyone who wants to be able to go really into detail on the research and discussions around this to Pete Maliaris. He has a Mastery of Lower Limb Tendinopathy online program where he is a leader in the field. He's one of the main people that has influenced this presentation today, and I fully encourage you to be able to check out, because a lot of the details around certain topics I simply don't have time to be able to go into in this one webinar. But what I have done is taken the general most important clinical themes to be able to be going into our creation of rehabilitation for these people. Okay, so I'm going to bring up my presentation. To take us through it. Because loading is absolutely fundamental. How much loading is a challenge? Too much, not enough, over what period of time? That is the dilemma that faces us if we are the person who's experiencing aches and pains. And for us as healthcare professionals, helping people who are coming to us for help with that. So we use a concept developed by Scott, or introduced by Scott Dye way back in 2005, around the idea of a metaphor for being able to understand load through the envelope of function. And I'm going to share this explanation that I pre-recorded in Australia last year to introduce that.
What are they fear avoidant of? So that could be bending down. It could be, I don't like lifting. Every time I lift my arm up, it's a problem. That could be a sport. But we get it in there because those become what we're thinking about when we're programming where we want to get someone to experience. Whether you do it in a Peter O'Sullivan way and say, you don't like bend down 100 times, or you do it a little bit more creatively, how we're proposing, that would be clinical reasoning yourself. And at that point then, I will connect to the concept of load management. So everything up to this point has been neurophysiological, pain and change in processing. We use Scott Dye's envelope of function model. Have you heard of it? If you haven't heard of it, Scott Dye is a surgeon, orthopedic surgeon, come up with this concept of the tissue homeostasis pathophysiology of knee pain, was what the basis of his 2005 paper was based on, and we will draw it on here. So we'll draw a line. If I had my chalkboard here, I would do it with you, but we would draw a line something like this, and we would label these axes. So we'd say that this is something that you can do a really high load activity. We'll label it load. This one will say something you can do much more often, frequency. Everything that you are able to do comes somewhere underneath this line that we're drawing, which is this concept of envelope of function. Have you ever watched any endurance sports or anything when someone's really pushing the pace and you hear the commentators say they're pushing the envelope? That's the sort of question I'll ask someone to see if they've generally heard of that concept. Because then I will want to know what would be a high weight for you to lift. And I would get an example of whether it was being able to lift a staircase at home, or whether it was, I train in the gym, I know I can do 92.5 for 10 reps for 3 sets, and whatever it may be that accurate. But you can draw on a high load activity, something you can do less, something you can do more of, and lower load, cycling, running, walking, whatever it may be, labeling it on here. Then everything else, walking up the stairs, walking to work, driving to work, would be somewhere within here. To be able to then paint this idea of pitching things just outside the envelope of function, that would require you to in some way adapt. We would then ask, and I'll give an example. If you said 92 kilos and I didn't give you 92 kilo squat, I gave you 150, what would happen? Draw it way outside the envelope, illustrate the fact that it's way beyond our current capacity to be able to go right then. But would it be possible to ultimately get there? Get that buy-in for someone to say, how would you do it? Well, again, this envelope of function is something that's a dynamic model. It's not a thing. I can't get someone's envelope in this cup. It's a heuristic model that you only establish by doing it. There's no textbook that's going to tell me what your envelope of function is for bicep curling or for bending down. You only find out by doing it. But when you can get this idea that the envelope can shift with good programming, pitching just outside your current capacity, you can also get the fact that the envelope can go the other way. So then when you can bring the envelope down, and the envelope is now not up here, it's now here. We use an example of if you go into space, what happens? There's no gravity, so when you're out for 6 months and you come back, astronauts come back, they have to literally walk again, their body's adapted, our bodies are amazing things. Their envelope of function has reduced accordingly. You don't have to go into space to be able to say, so if you stop doing X, Y, and Z for a period of time, is your envelope of functional capacity for that thing expanded or shrunk? People generally can grasp the idea to be able to say, yeah, my envelope of function for that thing is pretty low. We will then use this to be able to explain. I'll use myself. I'm white and I'm Welsh, and have I arguably got a big or a small envelope of function for sun tolerance? Small. So I will use that to be able to explain that this envelope of function is a concept. If I was to suddenly, it's not been too hot for us since we've been here. If I was to be here in the middle of the summer, it's 40 degrees. What would that would be analogous to this one that's way outside my envelope of function, frank injury, or I would burn. But could I grade my exposure to being able to do it over time? Probably. That then leads us into be able to explain the interesting post I was talking with Jace about. Is there any research to be able to say that conditioning the error actually reduces injuries? And it's an interesting question, and me and Paul were talking about it. It's an impossible study to create because you couldn't get 2 groups. One of them conditions the error over time, progressively loading in these awkward positions. The other group doesn't, and then make a situation where they suddenly step off and see who sprains their ankle and who doesn't. It's an impossible study. And if you put your head into and bury into any one component of anything that we've talked about so far, you would ultimately get to a point where it would be irrelevant. But what this concept of envelope of function leads us towards is the fact that we've introduced this idea of how tissues, based on different metabolic rates, adapt at different speeds. Connective tissue takes longer to adapt than muscle, and we can expose our connective tissue to load and it will adapt. We have an envelope of function for inversion. We have an envelope of
function for inversion. I'm just going to pull up a little clip I took in Nepal of a local carrying goods up a mountain to demonstrate better than anything I could say.
I'm filming this for our students to show. Function for valgus. We have an envelope of function for low back flexion that in the same way is trainable slowly over time. So we use that to be able to explain that a component of your training is going to involve awkward positions that if we want to be able to bend down again, we're going to have to build up your capacity to be able to bend down again. One component of the program. At this point, Generally, people have been able to follow a lot of information because it's visual in a way that if I was to just talk it, it would just be all like, oh, what the hell's going on? In my experience, creating this and getting to this point has been the biggest difference between being able to actually get people into a position where I can help them or not. Because we can then be able to say, so we're in the right place. We want to be able to cross this metaphorical bridge that we call getting you to this side, which is to make you more robust. So this side of the model here would be typically chiropractic or physiotherapy or rehab. And most people can connect that they've been back and forward in this side and that they never really actually did all the things, taking care of the things that involve them to being in control of the program. This side may be more ups and downs. This is the Toblerone effect that Louis Gifford would talk about. Some days we're going to be sore, we're going to have to poke things, but the general trend is that we're going to be getting more resilient and more robust, both psychologically and physically and socially, if we're engaging people in social prescription, or our programs are basically also addressing the social side of stuff. The point of our programs, though, is to be able to get you so that you don't need me, you don't need anybody else. You are able to self-manage. Unless you have a new complaint and you want to have our help. And I will say to people, if we can start you day one this side of that bridge, then we do. Because what we've got is a diagnosis sensitized alarm system, and we've got this toolbox to be able to bring it down. On top of that toolbox is knowledge. I've already started it. Maybe this would be all the education someone naturally needs. Maybe someone else needs a little bit more to dispel some of their maladaptive beliefs that we maybe have addressed in the history. We use that Louis Gifford A, B, C, D, E, F, W to gather those. Underneath that, we've got exercise and movement. So we framed the idea that we're going to be using new movements. We framed the idea that we might be doing movements that's going to be relaxing, engaging things that they enjoy doing again, giving them permission to do so, maybe, and frame the fact that we could be loading awkward positions. Okay? Exercise and movement is what most people expect of us, but then we say we're also going to be pacing the things that we're boom and bust. We're going to be grading the exposure to the things that we're fearful of. And manual therapy is on that list. So manipulation is something that people will expect coming to us, but needling, massage, depending on what your background is what your manual toolbox helps you calm someone's system down. We only ever use it as a tool to get people to hear. If we don't have to, we don't. And a lot of my clients have never had any manipulation. I prefer not to do it if I can help it. Goal setting is the bottom one on this. So that's hit that box there. So then we will be able to paint this journey of sensitive to robust. They're not necessarily sensitive, but it's just what we call our programs. And as Paul said before, the logo is to illustrate that we won't necessarily have a straight line. Relationships, business, rehab programs are not straight lines of success. We will have ups and downs, and actually in the process is probably where the magic happens. But we can't do all this in one session. Any questions?
A whistle-stop overview of not just load management, but some of the adjunctive and more holistic components that should be included in any given presentation that's going to come and ask for our help. And I'm just going to play this video of this chap in Nepal again one more time. It's a little bit smaller, but on our YouTube channel you can see it and blow it up to demonstrate how this person, and he's just one example of a very normal trend in their culture, has been able to expose the body to adapt. You can see the picture. This on the far left here is an example of how they load through their head. I actually brought one of these straps back because it's what helps really lock in the weight through their neck, and then they have to be able to bend forward to take the weight through their back, and they have this little stick, and some of these guys have 120 to 150 kilos, and they carried it all day, every day, up and down the mountain, right into their old age. The gentleman you see here would be in his 40s or 50s. And I even had a go at being able to hold these gas canisters, and it is hard work. I pride myself on being pretty fit and strong, and my envelope of function, or my capacity to be able to do what these guys ask their spines to do, would have led me to exceeding my capacity and running into a problem pretty quickly. But look at the ankles in particular.
I'm filming this for our students to show.
Amazing. And hopefully that just sets the scene here for how we need to appreciate the body is incredibly adaptable. Focus of this session is not going to be going into the spine and particularly into the neck and the back. We're going to be looking at some of the more common load management issues that are going to come to us in terms of tendinopathy in how we manage those, because in our workup we will hopefully have identified, and we're pretty comfortable with looking at that man walking up the mountain there, the imbalances and biomedical causes of pain presentations are generally not that relevant when it comes to pain presentations. And what will happen a lot of the time is that we'll be then trying to get across that something has changed in somebody's life somewhere, and particularly when it comes to lower body common persistent pain presentations, or where people have exceeded their capacity to be able to tolerate load. And I'm talking Achilles, I'm talking knee, I'm talking hamstring, I'm talking glute. There will be somewhere in their life through a diligent history and question session where we can see changes have happened somewhere. Have they started suddenly doing hill sessions? Have they started increasing speed sessions? Have they taken up recently developed motivation to be able to to get fit, and they're doing a couch to 5K, so all of a sudden their load, if we were to look at that over a period of time, has quite an acute spike. Maybe they've just got a new piece of kit like a Fitbit, which has motivated them to be able to get going more. A common one that would affect me a lot when I was training was pre-season. So I was an athlete that trained a lot, but then you'd have an off season where you would be deloading for a period of time, and you had to be a little bit careful when you come back into training, because suddenly your envelope of function for running has reduced as we've stopped training for a period of time, and we need to be able to phase in nice and consistently over a period of time to be able to get back into training. So changes in it's not just about doing something new. It means it could be that we've stopped doing something for a period of time and then we get going again. Has someone changed their footwear? So there's a big period in the last 10 years of shifting towards a primitive barefoot style of running, and I can buy into that around the idea that the foot's got so many joints and it's designed to move, and very restrictive footwear stops that movement. However, if we transition very quickly, those joints in the feet, those joints in the ankle, and then up the connecting chain haven't had time to be able to adapt. And that's something that I actually experienced myself, as I adapted to barefoot shoes about 7 years ago. So that I did it very slowly, and for about 5 or 6 years, I had no problem whatsoever. And then I bought one pair of shoes that was maybe your more traditional trainer, that was a bit more restrictive, wore that for 6 months, then went back to my barefoot shoes, and I ran into a pain on the top of my foot, completely out of apparently nowhere. But put my more restrictive trainers back on, and no problem whatsoever. So I let my body adapt over a long period of time to barefoot, then in a short period of time adapt to restrictive one, going back to barefoot. That sudden change was enough for me to develop a pain in the arch of my foot. That is another example. Change in surface of running, so being able to go on road or off road may be a difference, and training a lot under fatigue. And where that is relevant is because our muscles often act as force absorbers, and if we get to the point that we're training a lot under fatigue, then we can put a lot of extra force onto our tendons. When we look at the upper limb, this is where we will delve much more into being guided by the expertise of Jeremy Lewis, and what the research out of Sweden shows here, with presentation of overhead, presentation of of shoulder pain, it will be significantly higher prevalence of people who work overhead. Will be people who are hairdressers, people who are painters, and so I'm just checking what my next slide was. And that again will be no problem if it's something that we adapt to, but is that something have had time to adapt to? Is that something that's a change somewhere? So if we suddenly just got a dog where we're starting to throw a little bit more, is it that we've increased work hours? Have we changed our job? So these will be the questions that we will be wanting to find, because that overhead position is one that is relevant particularly in shoulder. Has evolution failed us to be able to tolerate these positions? Little look into the skeleton around this on the left here is our skeleton today, very barrel shaped compared to a chimpanzee, which is much more triangular, and the implications of how our shoulder blade will sit on this barreled one versus this triangular one, which is oriented much more upwards, means that monkeys are much more designed for overhead and brachiated, whereas we are designed for being able to be in this throwing positions that much far superior to a monkey. Does it mean that we are not able to be overhead? I don't think that is the case. I am a big advocate for I am a big advocate for gymnastics and play and very, very primitive ways of moving. And again, I think it probably lies much more in the rate of change to exposure to these things than it being inherently a bad or good thing. So I think that is an important point that I want to be able to get across, that we are designed for doing these things. But again, from the literature, it seems to be at the rate of change, and that's what we've got to be able to find in our history, where that change has taken place. Another interesting difference in terms of our ability to throw and shoulder function is the movement at the pelvis. We have the ability to move through the pelvis and rotate through the pelvis much more so than a chimpanzee does, and that's also very relevant for shoulder presentations. So that's what we're talking about really when we are saying there's been a change somewhere in the loading profile of someone's activity. There will also be internal changes that can lead to our tendons and connective tissue being less resilient. That could be that they're getting older, age, hormones, so menopause and taking synthetic hormones can change our tendons' ability to tolerate load. Metabolic processes like diabetes and cholesterol, so that's just that fundamentally taking us into our general well-being, or comorbidities. These have an impact on the health of our tendons. Smoking is well known and documented to have an impact on our tendons' ability to take load, which the right cocktail for all of these, maybe in isolation or with something that's changed, leads to the potential onset of a painful tendon. And in there is repetitive movements that could be the final straw, building on all of these, that then ultimately leads to someone coming and saying, you know, I've developed heel pain, and it's come on apparently out of nowhere. Could be a mixture of these internal variables as well as the external ones that lead to the alarm becoming protective, which is a metaphor that we use for getting across how we understand pain. There's a couple of really important factors that we're going to want to identify, because they're going to be provocative in a tendon that has become painful. And the first one we'll hear people talk about will be compression. Now, that doesn't mean compression like compression on my head here. It means once a tendon has become irritable, there will be specific movements that, when either stretched or pressing on the tendon, will cause compression of it that will be provocative. Okay, and I've wrote the movements in here because these are going to be the common tendons that we're talking about. And the Achilles is the biggest tendon in the body. That's the one I'm going to use as an example I pulled from Pete Malliaris's work here. This is the Achilles as it turns from tendon into fibrocartilage into the calcaneus, or the heel on the back here, and the foot would be running along here and the shin would be running up here. And now if this tendon, for whatever reasons we've just gone through, has become painful and it won't settle down, if we take this foot into dorsiflexion, so take my knees over my toes, this is going to be compressing the underside of the tendon. So as the tendon's inserting here, the compression is going to be happening here, and that is going to be provocative. And that's going to be consistent across different movements for tendons that will be pissed off. And for the patella, that will be knee flexion. For the proximal hamstring, it will be hip flexion. For the glute medius, it will be hip abduction. And for the rotator cuff, it will be elevation, which could be in front or out to the side, but it's overhead. Okay, so it will be coming up into one of these positions, which is going to be the provocative or compressive movement on the tendon. And why is that the case? Have we not adapted to be able to tolerate compression? And again, hopefully you saw from the videos of me brachiating there before. And if I was to play this here. You know, saying that knee flexion is the provocative one in the patella, does that mean that it's necessarily a bad thing? Not what we're saying. We can tolerate compression. This is a very compressive movement here. It is a problem once the tendon's pissed off. And that's important. Our tendons have this fibrocartilage transition here, which is designed to take compression. But what we're probably not designed for is the fact that our lives now mean that we're very boom and bust, we're very sporadic with our loading approaches. That means that we can, in some way, exceed our capacity to be able to tolerate through here. And once we've done that, then it's a problem. So that's where load management is going to be able to come in, and having an awareness of those movements is going to be important to know, because they're going to be part of what we're going to need to test in each tendon and take out and then bring back in. So that's the first factor, which is going to be compression. And the second one is going to be high and fast load. Okay, and this is not as simple as straightforward as just saying high load, because if it was, then everyone who was just doing the really heavy work or the really fast sprinting would be the ones who get the problems. That's not what we see. It is, again, a problem once it's provocative. So that in this example here, this is an Achilles 5-second maximum voluntary contraction, really slow over 5 seconds on a leg press, which causes a force of 3.6 body weights through the tendon, and a load rate of 0.7 body weight. So that's a very high load, but done slowly. The load rate is 0.7 body weights per second on the Achilles tendon. Now in hopping, which may be far less external load, each hop is 6 body weights. The hopping strain is 8.3%, and what that means, it's done over a much faster period of time, which means the load rate is 15 body weights per second. 15 body weights per second compared to less than 1 body weight per second in a very heavy, slow contraction. Similarly, if we look, and that's in the Achilles, similarly, if we look at an example in the quad, if we do a loaded patella, loaded squat, so very heavy, slow resistance on the patella, the tendon force in the patella would be just under 5 body weights, strain 5 to 10%, and the loading rate would be 1 to 2 body weights per second. compare that with a horizontal hopping force. So like a triple hop, bam, bam, bam. That would be, again, less external load. The tendon force would be 5.17 body weights per repetition. The strain rate's very similar, 5 to 10 seconds, but the speed in which this takes place means that the loading rate is 38 body weights per second. And again, this illustrates that the speed of the contraction is a really important factor in terms of loading, not just high load. In the shoulder, when we look at someone like a picture here, I mentioned in the start, this is why lower body seems to be also important for the shoulder, because by the time this pitcher is releasing the ball, his shoulder is turning at 170 kilometers per hour in terms of the degrees that the shoulder's passing through. Very, very fast movement, and that's going to be important. So stretch shortening cycle, which is plyometric, or this rebound load, is going to be the second provocative factor in our tendon rehabilitation. So that's really important to be able to bear those two things in mind, because this is going to be what we're going to be needing to test and probably take out to then create a load management gradient to bring those back in. Neither compression or stretch shortening cycle or high and fast load are in of themselves a problem, but couple that up with maybe some internal factors like hormonal changes, maybe some poor health habits like smoking, or simply just training errors, which is what we introduced at the start, where we've changed something a little bit quicker than our body was able to adapt. Excuse me. And that's what when we see this cocktail that leads to our connection of the tendon, or the tendon which is otherwise designed for compression, and the morphology of the tendon, particularly the Achilles, for example, it's long, it's designed to be able to take these stretch shortening cycle loads. But some of these factors all combined, coupled with the fact that we do have lower blood supply to that tissue, leads to a presentation that can persist and can become very, very painful and debilitating and frustrating, because we often can't understand why and what we have to do to be able to get going. This is an overview of what the rehabilitation process should look like in terms of load management. Is that we're going to take the stretch shortening cycle activity and probably the compression activity down, but the stretch shortening cycle is going to be the most important one for being able to reload, because that's going to be most relevant, particularly for people returning to sports. We need to stop, we need to load manage those, bring those down, and then over time, and we're going to talk about that as we work through this session, bring them back in. As soon as possible, we will be introducing heavy, slow resistance into the tendon. That is the most superior way that we've seen for being able to drive and make changes to the tendon. It's going to be slow, heavy, slow resistance, and we get that in terms of isotonics if we can as soon as possible, and that runs all the way through, arguably indefinitely. Strength is an enormous health, an enormous beneficial thing for our health for a multitude of reasons, not just tendon health, but as we keep that heavy, slow resistance running through, specific for the tendon or the joint that we're looking at, we would have a load management gradient to be able to work back up through. This is a running example all the way to return to competition, which by this point will be higher than the load that was provocative when they led to their initial presentation. That's the goal. Now, pain and tendons and tendinopathy can become blurry, and it can become very very confusing, because it isn't straightforward. But being aware of the fact that painful tendons will generally have local pain, that will be provocative when we load them, and that shouldn't be provocative when we load them, which is another way of saying that a pain experience from something that shouldn't be painful, which is allodynia. It tends to be local, and we can palpate it. It tends to settle down as soon as we stop loading it, and it's a proportional load pain relationship. So when we do the provocative activity, it hurts, and then when we stop, it stops. Stretch shortness syndrome can flare it up, even in people who haven't got an otherwise sensitized system. And that's why we're going to be needing to load manage that. But sometimes pain can give us lots of, not sometimes, often pain will give us very weird presentations, and that's where we're looking at some of the more central mechanisms that we are probably making much more of a point of getting across in our management of neck and back rehabilitation, where we look at nociplastic or central mechanisms. But these consistently run across these persistent peripheral limb pain tendinopathy presentations as well. So how do we look at that, and how do we make sense of that in actually putting the clinical management program together? I pulled these slides here from Jeremy Lewis, which is where we try and get an idea of where the symptoms are coming from. In the shoulder, for example, he pulls up psychosocial factors. So it could be referred pain, could be a specific tissue diagnosis. We could have frozen shoulder, or there could be a dislocation or a medical pathology. It could be posture or sustained posture that's a problem. It could be soft tissue, so there could be a rotator cuff tendinopathy or bursa or subacromial pain, and then peripheral sensitization and sensitization, which is probably more accurately discussed as nociplastic changes, because it's not necessarily a problem. We're designed to be able to have these changes in any pain presentation. But when we look at it and we try and actually pull this apart, it's probably much more of a muddled up presentation, all overlapping to some extent. And how important is that in tendons? Because we see tissue changes, and again, for a much more in-depth dive in on this, definitely go to Pete Malayaris's work. He's looked and gone down all the rabbit holes. A lot of them come to the point where we say we don't know. Things like biomechanics, things like tissue changes on scans. These are all important, but there does seem to be some dysfunction in terms of the pain that we are processing from a tennis elbow, from an Achilles tendinopathy, from a patella tendinopathy. People who don't have pathology generally don't have tendon pain. There's one interesting caveat. So pathology does have some relationship with pain, but it's only weak, okay? 59% of asymptomatic, 59% of asymptomatic people will have pathology. In the upper limb, swimmers, something like 90% of them have been reported to have cuff changes on scans, but no pain. So we don't have this clear relationship between tissue changes and pain. And as we'll dive in a little bit later, we don't have to change the tissue to change pain. But where do we stand with that for putting a plan of management together? We can't be telling that from any ultrasound scan or any scan of the tissues. The person is going to tell us the pain experience, and that's where some of these central mechanisms become really important around how we're going to manage our tendinopathy or persistent peripheral limb pain presentations. This Van Greensvan's paper has tried to update the challenge of a contemporary approach to musculoskeletal presentations that will include some central changes. And I've included in here where they have gone, make that a little bit larger, gone into the quantitative sensory testing, which used to be used much more for persistent neck and back pain, and we need to be able to try and see, is there changes in sensitivity in peripheral presentations like the ankle and the knee and the shoulder that we can measure. Some of these kits for being able to measure hyperalgesia and allodynia and temporal summation are inaccessible and expensive, but this paper looked at, do they correlate with some of the more clinically available ones that we can use, like putting an ice cube onto skin and seeing what the response is. And it does carry across accurate enough for us to be able to use them. How we interpret them then probably becomes more relevant. And I have got some videos to be able to help guide that process, because this paper also from 2020 this year by Darren Beals looked at a pragmatic approach for a full approach to sensitivity in musculoskeletal practice. And I'm going to pull up, there's 4 main tests that we can do to be able to see if we can elicit a change in sensitivity of the processing of this elbow or this shoulder or this knee. And the first one is going to be light touch sensitivity, okay? Or otherwise to be able to test for allodynia or hyperalgesia.
But then it does spread somewhat down your leg, and that can be quite a sharp and burning pain that shoots down your leg. That's right. Yeah. Now, because of that, and also you described to me that having your sheets on there at night is a bit of a problem, and you don't like having your clothes on there. I think I want to look at the sensitivity of this first. Okay, you happy with that? Yeah. So I'm just going to go through a number of tests to assess that, and we'll just talk about that as we go on. So first of all, I'm going to do like a really light touch. So this looks like a needle, but it's just like a piece of fishing line. Can you feel this on your hand? Yeah. Is that a problem, or is that okay? All right. So if I do this on the other knee here, can you feel this? Yep. No problem with that? No. And if I come down the leg, can you feel that? Yeah. All right. So now we'll go on this leg. So I'm going to just go in the same area. So are you feeling this? Yeah, I am. And how would you describe that? That's sore on that side. So is that different to this side for you? Yeah, that side's comfortable. That's not comfortable. Yeah, and where are you feeling that? Under where you're poking it. Just where I'm poking it? Okay, good. And then if I come down the leg a little bit, how's that? That's okay, down there. That's all right. So just let me know if it's getting too sore, but I'll just go again. So for you, that's completely different to that? Yep. And would you describe that as pain or just uncomfortable? That is pain. Is that like the pain you get at all? Yeah, it is. Yeah. Okay, good. What do you think that means? I don't know. It hurts on one side, doesn't hurt on the other. Yep, okay, good.
So that's light touch sensitivity assessment done by Darren there. Again, one of the challenging things to be able to move with tendons is they tend to be provoked by specific loading of the tendon. But in a cohort of people, and it's not particularly rare, they are very irritable and very sensitized. And these are tests to be able to see if we can get any more of a clinical picture around how it's going to guide our management. Because those irritable ones are the ones that tend to be a little bit more challenging than the ones that are just purely loaded tolerant. We've got loading strategies for those at the end of the session. But I want to take through so that you've got an idea of how to be able to test these potentially sensitized ones. So the next one is going to be just an example. If you don't have a Von Ferrero, I use a little fishing, bit of fishing line to be able to test the different side to side. This is being able to do it with a tissue.
Okay, so we're about to have a look at some assessment of your back, Jenny. But just to clarify, you've had this for nearly 12 months now, where it's really been pain in your low back, but it's just been broadly radiating down your left leg. Yeah. But the pain's more localised to the left side of your back. And you didn't have any specific injury or anything when this started. And you've had some scans on your back that are actually clear, so they don't show any signs of disc problems or pinched nerves or anything. That's right, yeah. That's your understanding? Good. So we're just going to do some tests first, because you've described that this area is quite sensitive and can be easily stirred up, and similar with your leg pain. So we're going to do some tests around sensitivity. And these ones are just of your skin, so we're interested to know, even at a skin level, is your back or your leg sensitive, or is the issue deeper than that?
Okay, so we'll do these tests first. If you just stand and face me back to me, good. So I'll use this tissue, so it should feel like if I brush on your arm, it should feel like a tissue. Can you feel that?
Yeah.
So now I really want a comparison in what you can feel on the left and right sides of your back. So if I do the right side first, can you feel that?
Yeah, I can.
And what does that feel like?
It feels like a tissue.
Okay, so similar to your
Yeah.
arm.
Yeah.
And if I do it on this side, can you feel that?
I can, yeah.
Okay. Is that different to the right?
Yeah, it's more on that side.
So is it painful or you just feel it more?
Just feel it more.
And if I compare this again
Yeah.
to this, do you feel it a little bit or a lot more?
Yeah, quite a bit more on the left.
So it's clearly more sensitive,
Yeah,
but not painful.
that's right. Yeah.
Okay, good. Okay, so similar to what we did on your low back, we're just going to repeat some of that on your leg now.
Okay.
So we'll use the tissue again,
Yep.
which feels like a tissue. So when I brush on this thigh, compared to this thigh, does that feel any different?
Feels the same.
Okay. And then if I brush on your lower leg there, can you feel that?
Yep.
And can you feel that?
Yep.
And do they feel any different?
No, they feel the same.
So I'll just come down onto your foot now. So if we do that on your foot, compared to this side, any different?
Exactly the same too.
Okay. So interesting, it was different on your back, but there's no obvious difference there. And that's in the areas where you do feel those symptoms
Yeah.
sometimes.
Yeah.
Let that run there with Tim Mitchell from Pain Options Group in Australia. Again, just to illustrate how you would want to be testing different body parts that are not painful, and then comparing left and right or different limbs of a painful limb, building up this picture around sensitivity. Okay, next one is going to be sharp touch sensitivity and how we would go about that.
Okay, Jenny, now we're going to do a similar test, but I'm going to use sharp. So can you feel this here?
Yeah, it's sharp. Yeah.
Yeah, it's okay though?
Yeah.
Okay, so same routine. First of all, I'm going to go on this side, this knee. What are you feeling there?
So it's sharp.
Yeah, okay, so that's normal. And then down here.
Yeah, sharp.
Okay, so we'll just go to the other side.
That's not good.
Yeah.
Yeah,
So it's different to the other side again.
it is. It's different. Yeah.
And where are you feeling that when I do that?
So I can feel it where you're touching, but I can also feel it in that spot where it goes down my leg.
Oh, so that's reproducing that pain down the leg.
Yeah.
And so you would describe that as more painful when I put this on the knee there.
Yeah.
And lower down,
That's not comfortable down there either.
so that's different to that side.
Yeah.
Does it spread there, or is it just
No.
where I'm doing that?
Just where the toothpick's touching the skin.
Okay, so that's a bit like the light touch one that we did as well, isn't it? So a little
Yeah.
sensitive.
Yeah. That one was worse.
Yeah. Any thoughts on what that means yet?
It seems to be more sensitive on the
Yeah.
outside than
I
the
think
back.
that's a fair comment.
Notice the communication that the guys are using to be able to let the patient come to a conclusion that one side may be more sensitive than the other. Opens up the door for being able to discuss sensitivity and how we might work with that, because that's where we would be looking to be delivering a loading tissue-based program, but also the pain, maybe more of a biopsychosocial pain component around the program, that someone's going to be open to it by the fact that they've been able, and it makes sense, that a joint is more sensitive. Okay, mentioned before from that 2020 paper looking at central sensitivity in musculoskeletal practice. They talked about an ice cube, which can correlate nicely with some of the more fancy quantitative testing, this is how you might run that one.
Okay, Jenny, is that settled back down after that last bit of testing?
Yeah, it's fine.
Okay,
Yeah.
so now we're going to try your response to cold. So I just want to try this on your hand first. Are you feeling that?
Yeah, I can feel that.
And what do you feel there?
Just cold.
Yeah,
Yeah.
not uncomfortable, painful. So just on this knee, what are you feeling there?
Just cold. Yeah. Similar to my hand.
Same, not painful or uncomfortable. Okay, so now I'm going to go to this knee. You ready?
Yep.
So I'm just going to hold that.
That's really uncomfortable.
That is. And where are you feeling that?
All that whole area under my knee. I can kind of feel it going down my leg.
Spreading the pain down your leg. I've taken it off now. What's happening?
It still feels like it's on there.
Yeah.
Yeah.
We'll just give it a few moments.
Yeah.
Sometimes the last one can linger for a little while. Does it feel like it's settling now?
It's less. It's not gone, but it's less.
Yeah. Okay. We'll just give it a bit more time,
Yeah.
and I think that will settle.
Most of us have got access to an ice cube, and that is a useful test to be able to run for thermal sensitivity. Blood pressure, I'm going to play this one because it's another one to complete a little battery of tests. Again, and it doesn't require any kit.
Okay, how are you feeling, Jenny, after those couple of tests? Does it feel like this is getting worse for you, or is it leveling out between the tests?
What it normally is.
Yeah. Okay, so you're happy that we keep going? Because there's a few more things I'd like to check.
Sure.
All right, so the next one, and that was sharp. We're going to go with blood pressure. So if you just keep me in your hand, I'm just going to use my thumb and kind of press in.
Yeah.
That might be light, moderate, and kind of firm.
Yeah.
You happy with that?
Yeah.
Okay, so if I press on your knee here, happy with that?
It's like pressing on my knee.
Yeah, and just to those different pressures, that's
Yeah.
fine. And we'll go down here as well. So this is just very light, moderate, and firmer.
Yeah.
That's all comfortable for you?
Yeah.
So we'll see how we go on this side. So just on the inside of your knee here.
Oh, that's uncomfortable.
That's uncomfortable already.
Yeah.
And where are you feeling that? Is that one spreading down your leg as well, or is it just where I'm pressing?
That's me pressing.
Yeah. And would you call that painful, or just uncomfortable, or just different to the other side?
Quite painful.
Yeah. Okay. And then similarly down here.
Yeah, a little bit less than the knee, but not comfortable.
Yeah, so a little bit more pressure, but not great. Okay, good, thanks. Maybe I should be checking the other side of the knee, but that's not really complicated.
So that's a really useful little battery of tests whereby you can do one of them or you can do two of them, but if you do all four, it helps build a clinical picture. If you're doing that over the shoulder, over the knee, as was demonstrated in those videos, helps build a picture around some of the more sensitive or some of the more confusing, strange pain presentations that can come with some of these presentations. So that should be really helpful. There's specific loading that's going to be required to be able to recondition a tendon that has become painful, and we're going to get to those. But this is exercise-induced hypoalgesia, which is where we can try and tap into some of the more general impacts, some of the more general mechanisms of exercise for downregulating some of these maybe central changes. And that's where being able to appreciate that things like the runner's high and what we call descending inhibition, for trying to be able to get a pain modulating effect of exercise. And this paper by Rice looked at the impact of one out of exercise and did some of that pain sensitivity testing pre and post the bout of exercise to be able to see if it has a tangible impact on how, on the sensitivity, on the thresholds of the body part. And in that paper, which you will have access to, is a literature review around different types of exercise protocols, the groups that they do it on. So this is chronic low back pain, chronic neck pain. As I come on to the next page, you will see fibromyalgia, shoulder pain, osteoarthritis, pain in the knee. You will see there's different groups, and then they have the exercise bout that they put them through, whether it's an incremental bout on a bike or swimming or resistance training, and then the measure in which they use the threshold of pain, whether it's temperature, whether it's temporal summation, so sharp input, and doing it multiple times, does it build? Does this an argument for central wind-up? And they did this in people who had persistent pain and people who didn't. And what you find is that there's a global effect and a local effect in where you do this testing. And across the board, this down arrow illustrates that there's a reduced threshold immediately or up to 45 minutes after the bout of exercise in people who haven't got persistent pain. We have an internal drug cabinet in the brain with that runner's high or descending inhibition, or these other systems that are probably contributing to it, like internal opioid system, endocannabinoids, rewards, serotonergic system, our immune system. These mediate a reduction in pain threshold across the body, both on a local effect here and distal. But what happens in people who have pain is, and have had pain for a period of time, for example, chronic back pain, or people who've got subacromial shoulder, subacromial pain syndrome in the shoulder, so not specific, something in the shoulder hurts, they will have almost across the board, if you look on this line here, an increase in threshold after one bout of physical activity, which is so important to be able to communicate the fact that it is, being able to normalize that there is a potential flare up, that it is a central mechanism as opposed to the tissue becoming worse or it becoming a structural sign of damage. And that's really important because we're not going to be able to engage in the exercise regime as long as we are interpreting that discomfort is a sign of damage. And I want you to be able to have access to this paper for being able to see a whole plethora of exercise protocols. There's a video here to David Butler explaining drug cabinet in the brain that we can give to our patients. And then how do we take this information to impact our clinical management? And this is taken from that Rice et al. Paper where they looked at the potential advantage of applying therapeutic neuroscience education and cognitive interventions like graded exposure within the context of physical activity to specifically help people with persistent pain reappraise the threat value that they associate and that they experience with pain and movement. And as a starting point, we can explain that exercise-induced hyperalgesia, or the drug cabinet in the brain as a metaphor, when delivering a pain neuroscience education intervention before delivering that exercise program. So the expectation is set, and the meaning of it is that there's a central change that we want to be able to work on. For example, when explaining descending nociceptive inhibition, clinicians can use a Socratic style dialogue that you saw Darren Beale doing there, sensitive this side, less sensitive this side, what does that mean to you? Letting the person come up with answers for themselves means it's much more likely to be sticky than anything that we're told or imposed on us. But explaining that descending inhibition in a Socratic style dialogue to explain that exercise can activate it, resulting in hyperalgesia. We can also highlight that people with persistent pain may experience the complete opposite, so hyperalgesic responses to the early stages of an exercise program, which can result in them experiencing more pain. And again, if we can do that in a Socratic style, that we lead someone to be able to challenge that it is not necessarily a cause of damage themselves, that it is a change in the sensitivity of the processing of the body part. This can be used to discuss the threat value of pain flares after exercise. E.g., does it imply that more damage to the joint or to the body part has taken place? And when that's integrated in a comprehensive pain neuroscience education program, people with exercise-induced hyperalgesia are expected to benefit through decreases in catastrophic thinking about potential exercise-induced symptom flares, increased acceptance about such flares, and improved confidence that these negative reactions will dissipate with time. And that is an example of a client interaction where I deliver pain neuroscience education to normalize these features around trying to get some of the benefits, all-encompassing benefits of exercise that is over and beyond just the tendon health, but the trying to work on the central mechanisms of pain and mood and all of these things that can impact the sensitivity of someone's pain. So that's a demonstration there that if you get access to this paper, you can see, or if you go onto my YouTube channel, the Back to Roots YouTube channel, you will also be able to access that. And just bring back to this Van Greensven paper that mentioned, that goes into, and the summary I've taken from here is that central sensitization or nociplastic changes are physiological and they are reversible. So that gives hope for the fact that we can have a sensitivity, but we can positively change that. Other important things to take away from the paper were that we don't have accurate ways to be able to test it. So those testing battery that I just took us through gives us information, but this is just like any other orthopedic tests. These just give us a bit of information that need to be fitted into the whole picture. So we can't make any two really solid conclusions around what the tests tell us. We must be careful that the concept of central sensitization is not used interchangeably with psychological manifestations. So it's not necessarily the fact that someone's centrally sensitized that they're automatic, that we assume that someone's depressed or that they are having lots of mental health challenges. This can just be purely a neurophysiological adaptation, and how people react to it is going to be different depending on the person. An individualized approach is going to be clear. We need to keep an open mind about this as a concept and be willing to evolve. But what is also true is that if we don't consider these things, we will not be able to put the plan of management together, meet patients' expectations, and engage them in the duration of a program that is going to get them to where they need to be able to successfully self-manage and get back to doing the things that they want to be able to do. This is from the Beale paper, which, if you're unfamiliar with some of the important terms around contemporary understanding of pain, like nociplastic pain as a definition, like nociceptive pain, like neuropathic pain, these different mechanisms. If we're unfamiliar with them, then we're not going to be able to get the most out of understanding the allodynia, having a painful experience with something that otherwise isn't painful for other people. That's allodynia. Or something that is painful, like a sharp input, is more painful than it might be in another person. And being able to appreciate that terminology, to be able to put an appropriate plan of management together. These are some of the things that are potentially unhelpful strategies for a clinician to be working with a person with a persistent pain presentation, tendinopathy or otherwise. And that would be managing the presentation like there is low pain sensitivity. There's a limited role for passive hands-on manual therapy treatment. We need to be shifting towards the active things, education and activity modification. And we need to be able to, another unhelpful strategy would be pacing to push through the pain. So a boom and bust approach. Blaming pathology. So we've had a scan to be able to see that there's changes in a tendon or there's changes on someone's MRI to be able to say that that connects with symptoms, because that's not necessarily true either. and not addressing beliefs and expectations. Just treating someone with an Achilles tendinopathy and not addressing the person that's attached to it and these factors is not what evidence-based practice is telling us to do. We need to be looking at these person-centered factors, which are all going to impact the pain processes. So some of the things that are going to be much more helpful are going to be giving a specific diagnosis, giving appropriate education, and that's going to be around things like updated understanding around pain, around being able to look for training errors in the loading of someone's training or someone's workplace. These are going to be incredibly important for buy-in and for being able to get someone to adhere. And because when we're going to talk about the timeframes of these things, we're looking at months, even years, for being able to apply some of these concepts around load management. Careful pacing, breathing and relaxing is going to help downregulate certain muscular tensions. General exercise, we talked about how being able to frame that people who have got persistent pain potentially have dysfunctional internal central mechanisms that mean that they can have a flare up after a bout of exercise rather than a runner's high benefit. So being able to normalize these things to then get those benefits and the more wider reaching benefits of exercise, which is about the closest thing to a health unicorn that we have. And then functional movements that normalize aberrant movement patterns, so people will learn to be able to adapt to get away from pain over time. So can we expose them to being able to normalize, to be able to normalize those? And there's a link there to the full report of findings. So I pulled out at the start discussion around envelope and function, how that fits into the bigger picture. There's a link there to the full hour-long version where I connect all the different pieces that we would put together in a rehabilitation program, which are going to include understanding, exercise, movement, relaxation, pacing, graded exposures to things that are important, manual therapy, depending on what adjunctive things you can offer, and goal setting, super important for buy-in. So that's the toolbox that we will be looking to work with in tendinopathy, just like any other presentation. But with tendinopathy, there seems to be some specific loading that is important. Or is there? Well, there's definitely going to be things that the research has shown that we need to be able to target load for the Achilles, target load for the patella, but where we used to see a lot of waiting on eccentric exercise, so just the negative part of a calf raise, for example, or a squat, is not how we currently understand it, and the overwhelming evidence demonstrates that heavy slow resistance, so positive and negative, is the important mechanism as opposed to just negatives. And there's no clear loading favourite. Principles that we are going to be addressing through here are going to be far more important, but at least 12 weeks and a pain monitoring model are the important factors that we do have to be able to put together. And that's often confusing because you're going to see the papers at the end, which are going to take you to rotator cuff management. They're going to take you to patella tendinopathy. They're going to give you guidance on hamstring, proximal hamstring tendinopathy, but they're going to be just guidelines because there is an enormous variation around being able to adapt that to the person that we can and need to be able to do. And a pain monitoring model is going to be super important. And the first thing is going to be assessing load tolerance to be able to get what their acceptable pain levels on a given pain tolerance test is going to be, because we want to be able to know if their pain if we can produce their pain, and then if it settles within a day or if it flares, because establishing what acceptable pain is a grey area. So I'm in a bit of trouble with my clicker here. But again, tying back to what we were talking about with the central mechanism, is even with what appears to be very clear, straightforward loading intolerance, we're going to need to be able to engage with a certain amount of discomfort and pain, and reconceptualize pain as an alarm. And it's not just a tissue damage ometer. There is different things that's going to be able to set that off. And this is an example in this video here of how I would introduce pain as an alarm, because we have to be able to have acceptable pain, not no pain. To be able to say with tendinopathy that we can't progress until there's no pain is not the reality of any person that you're ever going to see. There's different things that are going to be keeping someone's pain experience sensitized, and we need to be able to get someone on board the fact that we can have tissue damage and no pain. So an example that I use will be, you could ever think of when you've had a cut and you can't remember where you got it from. Tissue damage, you can see the bleeding, you can see the inflammation, but you can't remember where you got it from. No pain. Can you have the opposite? So can you remember, have you ever bit into an ice cream and had that brain freeze? Very painful, doesn't last forever, goes, and there's no tissue damage. So we've got pain and no tissue damage, and tissue damage with pain. So they're not one and the same. So that's going to be important to be able to come up with a numerical scale, like 1 to 10, like 0 to 10, or being able to put smiley faces on it and say that, for example, 3 out of 10 and below is mild, 4 to 7 is moderate, and 8 to 10 is severe, and maybe just having that mild, moderate, severe as a attachment to doing this exercise, and it was no pain. I do this exercise and it was mild, 2 or 3 out of 10. I did this exercise and it was 8, 9 out of 10. We have this framework of being able to get and associate acceptable pain, which we will probably, if we look at the literature that Pete Maliaris and the guys who specialize in this will use maybe 4 or 5 out of 10 as a yardstick for progression, but that meaning and that number is going to be different for each person. So that's also important. So the first step in assessment is going to be assessing somebody's load tolerance. So we have a battery of tests that is going to be looking at what we talked about from the start: compression, and then increasing compression on that tendon, and then high and fast load. So progressively increasing the stretch shortening cycle tests on that given tendon to be able to see what it can tolerate, to get that, what their highest tolerance in terms of a low tolerance test is. Okay, so in the case of the shoulder, I've got a battery of tests here that I'm going to do, including orthopedic tests for impingement, which tells us nothing about tissue dissociation, but what is the amount of movement or the tests and an acceptable amount of pain as a starting point.
I'm in the scapular plane, so this range here. I'm in the scapular plane, so this range here. Thumb up, just all the way overhead. Tell me if you have any symptoms through there. And back down.
Weakness from here
That's weak.
down there until there, yeah.
Okay, and if you do the same thing coming forwards into flexion. So you're able to get overhead to 0 point and symptoms come on or not?
Not so much. Yeah, a little bit under, right at the top.
Okay. I'm going to take you into a position, hand across your chest here now. So this is going to be, all I want to know here is this, does this hurt or not? So I'm going to place my hand here, rest your arm on my arm. Yeah. Oh, yeah. So I don't even need to press it there, that's reproducing it. Yeah. Come back down. Okay. I'm going to do a couple of resisted tests we talked about before. So I'm just going to lock you in here. You're going to externally rotate hand back towards me as far as you can. So that's going to be the movement. And back in. So I'm going to now build the resistance. Beep, 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 beep.
Yeah, a little bit right towards the end.
A little bit, but that was pretty strong. If we do the same thing here, if I give you a foot like there, go into external rotation, see if you can. So it's going to be that movement. Is that a little bit painful there already? Yeah. But then if we give a bit of resistance, yeah, painful, yeah, pull that one straight away. Okay, one final one. Stabilize the shoulder with my hands here. I'm just going to bring you forward. You tell me if there's any pain or at what point it comes on?
No, not.
It's okay as long as it's passive?
Yeah.
You do active on your own now?
Weak.
There?
Yeah.
So we've got a point there that angle's not going to be our reference point for retesting to try and calm that down.
So that's an example taken through the battery of first line compression tests for the shoulder. Each presentation in the individual lecture, you have a organized series of incremental tests to be able to find their highest or most difficult test that they have acceptable and then unacceptable pain. And once we find that, we don't continue. But if we can continue, then we would then work through the stretch shortening, incrementally increasing the stretch shortening cycle tolerance test. So I'll pull an example up here that was for my patellar tendinopathy that I've been working through over the past 6 months to a year for the for the slow and fast hopping. So we get a lot of information by going through just something like that. I can compare the side to side and qualitatively see if I've got better control on one side than the injured side than the other side. And also when we're initially testing, getting a rating of, okay, do this test, give me a number out of 10, or describe them as that mild, moderate, or severe, and then we work through and we get what someone's load tolerance is, okay? That is examples there because we want that test then that is their highest level, then would be where we would load manage. We take the things that are that equivalent to that in their life out, and then when we then put the program together, start off heavy, slow resistance, and we work through, and I'm going to show you the phases how we do that. But we want that same test then to have a lower pain response than when we retest it in the future, whether in a month, 8 weeks, 12 weeks. That is going to be our marker for being able to progress up the load management hierarchy. So that's going to be, the first part is going to be the load tolerance testing. And then we got to get at the load response, which is something that the person can only tell us. We can't do that. That's going to happen 1 day, 2 days after the session to be able to say the pain may have been acceptable during the session, but then it may have flared afterwards, which helps give us a bit more of an identification of when something's irritable or not, and helps us guide how and when we progress with exercise rehabilitation. Again, so all of those battery of tests you will either have done, they'll be in another presentation, or you've done them with us in another format. And this is, again, tying that to now, once we've normalized pain, to be able to paint the picture for how this process is going to look, to be able to say that we're going to be reducing, for example, hopping that I was doing there was caused a 9 out of 10 pain. Okay, so then we want to be able to take hopping on and hopping similar things like running out and load manage it. And we want to then, over time, we're going to have to bring that hopping back in. And it's really normal to be able, we need to normalize and expect that this, if we see pain in terms of the this Toblerone effect here, is we're going to get little flares when we're re-exposing to stretch shortened cycle activity. And this dotted line illustrates that over time, we're going to be working back up through that load management hierarchy, and to expect that little flares are normal. Okay, but we keep an idea and a gauge on their response, their load response, and they can track it after their rehab sessions for a number out of 10, if that's helpful for them away from us, to be able to ensure whether they're tolerant of that activity or not. Because if it's flaring for days at a time, they're not tolerant of that activity at this moment in time. We need to come a step further down the load management. Simultaneously, we might be working with adjunctive therapies, as I've introduced in the toolbox here. Non-steroidal anti-inflammatories. There is some research to show that the pain process of a tendinopathy is inflammatory. There is some research to show that it is degenerative, and it's some component of both. So there is some sense, especially in the first couple of weeks, to be able to be guiding someone through some anti-inflammatory medications. Ice can have a pain relieving effect. But of course, be aware that if someone's sensitive and you've tested them with ice and that flared them up, that might give you a bit of indication that that's not going to work for them, and may try heat. They may also be sensitive to that, but it could help. Manual therapy is another option. Not within my specific skill set, but you could tape, brace, sling, put orthotics. There could be other ways of stopping someone moving for a period of time. When I had that pain in my foot, as I described to you earlier, after a change of footwear, I had a coast-to-coast race across Scotland a week later, which was 105 miles, cycling, running and kayaking, and I thought that I'd done a stress fracture, or that's brought on some tendinopathy 7 days from the event. So I put a boot on that stopped me loading for 3, 4, 5 days before the event. So I finished my training, and I did manage to compete then the week later. But that adjunctive of putting something on to stop me and make me load manage through that week was incredibly effective. Shockwave therapy is a second line option for non-responsive tendons, and there is some research to show that can be something that we could use as an adjunct, along with other more invasive things like steroid injections and prolotherapy, which is an injection of a saline solution, which can stimulate a healing response. So in terms of load tolerance, from doing our testing, we will have assessed, and we will get someone will fit not perfectly into one of 3 categories. First one would be the moderate load intolerance, where their borderline symptoms have been reproduced. Flare-ups are short as soon as they stop doing it, and we are pretty confident to be able to load these in a logical, great load management, progressive fashion that will be in some of the papers that you have. But again, we still need to observe the response when we're doing it, when we're progressing them through the phases. The next 2 we will have are the severe intolerant. Okay, and there will be 2 types here. The first one will be that they have reasonable pain on load tests, but then they flare for days or even weeks afterwards. And these people will often be deconditioned from Pete Malliaris. That is his observation of seeing and specializing in tendons. The other group is with those people there. They are severely intolerant, but we can load those. We just need to make it very low relative to them and build really slowly and consistently. The severe load intolerant, which is where their pain is off the charts, and the pain is off the chart, flares for weeks, and with these people, there's going to be a big part of their program is going to be managing pain. Cognitive reappraisal of the meaning of it, and maybe trying to delve into some of the psychosocial factors, may even need co-management from specialty, but that's going to be, we need to be aware that if someone is getting load tests that's really flaring them up to the point where it's really disabling them, then we're probably dealing more with a pain issue, at least initially, until we can calm them down enough to be able to get going with loading. These papers all have a degree of acceptable pain. And again, it just reiterates that we have to have normalized this so that it can't be a surprise, and there has to be an acceptable amount of pain that we are able to work with in terms of progressing. Just to review here, that if we can start someone on this active side of the clinical pathway, the sooner we can do that, the better. and we've normalized these fluctuations in pain, and the stretch shortening cycle gradient is going to be consistently increasing over time, even though we maybe have taken it out in the short term. Something that we can use with people who are experienced with exercise training is subjective monitoring, like rate of perceived exertion, or as this Eric Helms paper couples that for strength training with reps in reserve. So how many reps you think you have left, and you stop maybe 1 rep short of failure or 2 reps short of failure. It's only effective if you have experience already in training, but with athletes who are going to have tendinopathy, they generally are. So we can be giving them 6 to 8 reps of this exercise and prescribing that we only go to within 2 reps of failure each set. And again, that means the intensity can be adjusted on the fly. That is also a guidance of the rep ranges to be able to be targeting some of the adaptations, which will be periodized through a rehabilitation program, from endurance through to strength, through to power, through to sport-specific movements and activities. This is a paper that we're going to be using for frameworks of progression. That is by Igor Sancho, who is a PhD of Pete Maliaris, where they give the programs 4 levels of or phases. And in the papers, you're going to see that as a theme, whereby we have pain-based exercise program, we have our testing, and then if someone's pain is greater than 3 out of 10 after load tolerance testing, then they would be level 1, which would be isometrics. Isometrics being contraction without movement for the benefits of getting an amount of loading going. There's some pain relieving effects that have been shown for some populations with doing isometrics, and that is the starting point. Pain level 2 would be that we've done the load tolerance test and we found the highest level that they have acceptable pain with, and then it settles down under 3 out of 10, and then we can do isometrics, but then we also do 3 times a week isotonics as soon as we can. Then over a period of time, once pain under 3 out of 10, on double leg hops, this is for Achilles, which is why double leg hops is the provocative one that they're using there, then that would be where they would introduce isometrics, heavy slow resistance isotonics 3 times a week, and then we have a increase in speed to stretch shortening cycle coming back in because they've tolerated it on the testing. That may have been intolerable at the start, but then once it becomes acceptable, then 3 times a week they're also doing some double leg jumps. And then level 4 would be that there's an acceptable pain on the next level of tolerance testing, which is single leg hops. And that then would mean that their program's looking very all-encompassing, high volume, and that's, again, we'll title that at the end. Isometrics can be done daily, heavy slow resistance, and the tempo within that can change from 3 seconds up, 3 seconds down to 3 seconds down, 1 second up, because then we've got the single leg hops, and once we can tolerate single leg hops, for example, we can be bringing running in back twice a week, and then we have frameworks within some of our specific programs for how we grade percentages of speed, of intensity, all the way up to return to play. This is an example that I will be wanting you guys to have as a framework for building these programs in terms of what the isometrics might look like. These are going to be different for the person and the phase that they're in, phase 1, phase 2, phase 3, phase 4, and the presentation. So whether we're talking about ankle, or as you'll see how I've adapted this for the shoulder, there will be similar situation there. But some guideline programming here from that paper around what the isotonics looks like. So 3 times a week, standing calf raises, 2 sets of 25. Seated heel raises. So that's a bent leg calf raise, 3 times 8. Hip abduction and hip extension. So there's going to be an inclusion of other parts and movements other than just the absolute minimum for that tendon. So this would be for an Achilles. They're doing some direct load on the Achilles, but then also a more global program around the other musculature for movement that is going to be relevant for the person. And that could be looking at some of the more general things as well, like the exercise-induced hypoalgesia that we might be putting somebody through, all the way up to guidance around what the running sessions might look like, which would be a warm-up of 3 sets of 20 double leg jumps, 1 set of 10 single leg hops, then running relative to the personal history of what was normal for that person prior. So again, that envelope of function discussion becomes important because we want to know what it is for them and what's changed. Remember, something in their life and their loading will have changed, so that's what we're going to be using to be able to build off. Essential management is going to be progressive exercise exposure for tolerance and function. Load management of provocative movements, so the things we've identified as compressive, so in the knee, deep knee flexion, we wanted to take those out. And jump in and plyometric, we're going to take those out to be able, and then education, also in and around all of this is super important. Looking at that triangle there, a lot of people will fear that they have to have surgery, and that's really the case, but unfortunately a lot of people aren't willing to go through what it takes to be able to do a fully comprehensive conservative program, because 6 to 12 months and maybe even longer is a tough sell. But that's where our communication comes in, to be able to get the most out of the base, the pyramid here of exercise and graded exercise and advice, occasionally then using adjunctive therapies to be able to facilitate going through that process and really giving ourselves the best chance of not needing the more invasive procedures. But they are appropriate in certain cases, and being able to review if people are simply not responding after 3 months or even 4, 5, 6 months. We'll look at a timeline from Tom Goom in a second. That would be important, because if someone's not showing any changes, then it at least means we may be putting the best program together, but it just means that we're not the right person, and we need to be triaging because they actually need a different profession that is going to be able to tackle there and support them through a process. So what's important in putting the progressive exercise together? And the first thing is finding the start point. It's one of the most difficult things around any rehab program, because it takes a little bit of trial and error. But that's where, from our baseline testing, where if someone is really flared up more than 3 out of 10 on tolerance testing, then we would find an isometrics for that joint, for that tendon, that is specific in the other presentations. But if they can tolerate isotonics in a heavy, slow format, 3 seconds up, 3 seconds down, we want to commence that as soon as possible, which would be level 2 in terms of Igor Sanchez framework there. We want to make a note of their worst load test, because that may be a decline squat for the patella, and we made a note of the angle and the rating of discomfort. So for me, I did that when I had my knee tendinopathy. I filmed, it's on my YouTube, and I was able to do a decline squat down to about 40 degrees, and then I would get a 8, 9 out of 10 pain. But I simply couldn't do anymore. So then that's my note, the range of movement, the intensity of the pain there, and then I load manage, and that would be my load test that I reference against after I've load managed for a period of time through doing heavy slow resistance, and then maybe trying to address some of the other factors that influence pain in a biopsychosocial approach. We return to high and fast load when the worst load test is reasonable. And again, that's where your baseline testing becomes important. Some key points for isometrics. Isometrics, as a reminder, just pull this up. So I will just leave that play, which is a soleus wall sit, which is a bent leg calf isometric. But these are level 1 entry point for start point, because if they can't tolerate isotonics, which is moving, then we need to be able to try and find a level of isometric that they can tolerate, as it's our entry for load. It's not a panacea. There has been research by Ebony Rio, etc., that have showed that these can give us exercise-induced hypoalgesia, in terms of the table from that Rice paper before, but they're not a panacea. Okay, but they can be helpful, but we've got to progress from these to level 2 from Sancho's paper as soon as we can. So what we might want to do is watch a set of these in clinic to be able to see somebody do, or via telehealth, or maybe even 5 sets. Because if you look at the programming from tendinopathy rehab, it's 5 sets of 30 as a guideline to be able to get going with these. That then gives us a target for being able to get started. And then we want to be able to program that for maybe one time a day for low tolerance, or multiple times a day if it gives someone pain relief. And that would be the feedback that we would get. Just going to turn that on mute there to be able to illustrate how I might set up for a hamstring isometric. And the point being here will be that we want as much resistance as we can within the prescribed time. So if it's 30 seconds, we want to be getting as heavy resistance, or and that's, we can do that for using weights. I've got lots of examples and videos around that. But it has to be maximum intensity unless someone's irritable. And that's when we might reduce the intensity right down to find that entry point. But as I said, that's where that little bit of trial and error is in that process. One of the really helpful things that we have, particularly in tendinopathy, is some strength goals in the literature that have been shown to be protective of future problems of tendinopathy. So, for example, in Achilles, seated calf raise greater than 1 to 1.5 times body weight for 6 repetitions has been shown to pull it up so I can show you. So this would look like this. So 1 to 1.5 times body weight for 6 reps, full range, seems to be a protective amount of strength for, at least for recreational runners, in terms of preventing Achilles tendinopathy. So you would look at your body weight, and then as a goal is to be able to say, well, what weight would it be for 1.4 times your body weight? So I've got lots of 20 kilo plates there, 20, 40, 60, that's 80 kilos. Okay, I'm 90 kilos, so I would be looking to get this up to 130 odd kilos. Okay, this is tough. This is going to be challenging for normal people without injury, never mind people who have got Achilles tendinopathy. And this is 3 seconds up, 3 seconds down. I'm doing this on a step here, and this position is a nice replication of the angle of running, and which is often provocative for Achilles. If compression is not tolerated, then we take the step out and do it on the floor. But that would be an example, and it's really nice to be able to set patients goals, because it's motivating. To be able to achieve those when this is going to take potentially a long period of time. Hamstring leg curl, 15 to 30 kilograms. This is from Pete Maliaras. So the 15 would be more of a sedentary person's end goal. This is all for 6 reps, 3 seconds up, 3 seconds down. 30 would be more your athletic. And if we're talking about a machine here, then it's important to note that this is going to take some familiarization and setting these goals for the machines that you have access to, which may not be in your clinic, but you will need to find somewhere that you can guide somebody to be able to access these things. It's a bit of an explanation going on there, but this is an example of the prone hamstring machine that we use to be able to weight these up, and they'll be able to set these targets for 3 seconds up, 3 seconds down. Patella, similar situation with knowing your machine, but it's been shown to be able to get 40 to 60 kilograms, seems to be protective. That's been figured out by Pete Maliaras in his facility down in Australia. And leg press, which is where we lie back on the machine and press up to 1.5 times body weight. Remember, this is heavy, slow resistance. So let's have a quick look at what the knee extension will look like. This is myself. I've got an explanation on the video there for you to check out, but this resistance is going to be within the range that's acceptable. So it may be the top range here is too uncomfortable, going too deep is uncomfortable. So we'd have a range of movement that we can work. Here's a 2-leg example of a 90-year-old chap that I've been working with.
One rep. 3, 2, 1. Really good stuff. 4 marble reps. 3.
So you can see there that I'm giving him a metronome. It's a 2-legged version there to be able to get an objective strength marker. And that's really important because these testing are the baseline that we then need to be able to test and compare against. And you'll notice that these are all for lower body. I've looked hard to see if there is an equivalent in the upper limb, particularly in the shoulder, and on personal communications with Jeremy Lewis, he confirmed that to his knowledge at the moment, we don't have targets of strength that seem to be protective in the shoulder. He has a PhD student who is currently looking into that to try and find a number. But as it stands, shoulders seem to be much more like back rehabilitation, where it's going to be relative to the person and their daily demands, as opposed to being able to see a consistent target like we have in the Achilles here for 1.4 times body weight as a really tangible objective marker. So again, that's just as we go into we've been talking about some of the sensitivity factors, consistent across here, much more relevant in the shoulder and subacromial pain syndrome, or the shits, something hurts in the shoulder, it's generally much more complex and a pain picture around the shoulder, where in the lower limb we can be quite accurate with setting these tissue tolerance based goals. Important to illustrate that with these, sometimes someone will come with a bilateral tendinopathy, and that makes some sense as well in the literature. A lot of these sensitizing mechanisms can be central, but we want to be able to train and rehab these unilaterally, because when we take the non-injured leg out, this is mine, we can identify and expose a lot of the intramuscular coordination that we've lost by not being able to move that limb normally for any period of time. So as I zoom in here now, you'll see that on my leg extension, the shaking that is going on in my muscles there, which doesn't happen when I do it with 2 legs. That's really common. So again, unilaterally training is important to be able to actually target the deficit of the injured or painful side. This was the strength testing, being able to get those 6-rep targets. So either clearly communicating with your patient how to do it, sending videos to do it away from him. If you're in the gym, you can do it with them, but that does take time. You've got to be willing to set that aside. Once you've got those targets or those numbers, they're objective numbers that we can then retest again against in the future. Some important exercise dosages that are going to be really important for appreciating and manipulating to the person in the different phases that they're in. But this is from Pete Maliaris, and should be somewhere that you keep safe, because depending on the phase of Iga Sanchez's work there, this will be the programming. So if you're going to be putting someone into level 1 isometrics, a target of 5 sets for 30 seconds, maximum intensity, rest 1 to 2 minutes between sets, tempo not appropriate because they're not moving, daily. So there's your programming guideline for isometrics, the maximum weight that you can do for 5 sets of 30 seconds. Endurance programming, 2 to 3 sets up towards 15 to 20 reps, 1 to 2 minutes rest between sets, 3 seconds up, 3 seconds down, daily. And you've got to take this with a little bit of a pinch of salt, because if you're doing 20 reps, 3 seconds up, 3 seconds down, that's 6 seconds per rep. 20 times 6 times 2, that would be a 2-minute time under tension. So that's going to be difficult. So the weight's going to be low. So as I said, these are frameworks for being able to program, and then we want to move on to maximum strength, or the heavy slow resistance of someone who's accustomed to exercise. I'll be probably starting them here in terms of what the research is showing, that the 6 to 8 reps of heavy slow resistance to be able to run through, because we can get more weight through or more resistance through 6 reps than we can for 15. That seems to be important. Being able to then program that for 2 to 3 times per week, and exercises specific for that joint. Moving on to the more velocity power-based stuff, which is going to be at a lower percentage of that 6 rep max volume, longer rest periods. That means 3 second negative, up as fast as we can, and we could even do that as down as fast as you can, up as fast as you can, which is what more like what hopping type tempo would look like, which is down as fast as you can, up as fast as you can, plyometrics 1 to 2 times a week. So that's going to be a reference point that you should be able to keep safe and guide it, building individual programming for the person. That will move into the power phase, and it flares and we have to come back. So then our programming might change a little bit, but that's our yardstick. So that's some of the key important components around. I'll just remind you, because that says number 2 there, what number 1 was, because I've talked through a few things there. Was how we are guiding the progressive exercise, and having a progressive exercise that's pain guided is the really important component. So that was point number 1. Number 2 is the load management. So stop doing the thing that is provocative. So in the lower limb, it's going to be generally your stretch, shortening cycle, plyometric things that is going to be running and sport-based stuff. And it's generally quite easy to be able to, as a starter point, reduce that by 50%. If it is running, then you can look at someone's weekly volume and reduce it by half, or even fully, if that is required, because someone is sensitized and it is provoked. With walking, it's a little bit more difficult, because it's not about saying walk at half speed. It's a bit then being able to try to say, can we reduce the walking around? So with my example, I put a boot on so that I was not putting any weight on that foot. We need to find a way to be able to load manage from the provocative thing, and their testing and the history is going to tell us what that is. For upper limb, we want to be able to reduce that high and fast load. So it could be the throw-in, it could be the lifting overhead. If someone is occupationally required to do that, then we've got to be able to say, okay, if we can't avoid doing this, can we modify it? We will want to be able to apply the shoulder symptom modification procedure from Jeremy Lewis for the instance that they do that. But it's our education that comes to the fore there then to be able to illustrate the reasons that, it's multiple meta-analyses, systematic reviews showing that surgery for subacromial pain is not superior to sham or exercise therapy. But what people who have surgery do is they take relative rest seriously. They load manage, they don't drive, they don't do their normal tasks for a number of weeks and months. 6 weeks to 12 weeks as a minimum, treating it almost like a fracture is what Jeremy Lewis and subacromial pain literature will tell us. So it's our job to be able to say, we need to be trying to reduce these provocative movements. If someone's a hairdresser and they're up in this position, just maybe standing on a stool takes them from this provocative elevation to being out of elevation. Could be as simple as that. Because the other really big thing that we get across here is that if we're saying we don't need surgery or these more invasive procedures, where ultimately you then have to have relative rest and you can't do almost everything with the upper limb, we're saying you just can't do the provocative activities and review the compressive and stretch, shorten cycle activities for the upper limb. It was elevation. and resisted external rotation as well when you get into that specific session. So we just can't do those things as for a period of time. But what else can we do that isn't provocative? And we should be able to be creatively guiding people to what those things are. But this, as Pete Malliaras will say, and I can attribute this just to add an anecdote, if that's worth anything, that I, as an athlete and someone who is notoriously boom and bust, I have to, when I go through these various aches and pains, load managing and stopping doing the provocative thing is ultimately the most important thing with people who are generally going to be your athletes. People who are sensitized and more your sedentary population and maybe got more metabolic and comorbid things going on, then there's probably more of we need to be able to get going somehow here, and coupling that with pain management. Education, communication, and how we support someone through all of this is important, because I don't know the best way to do this, and I've looked and I've spoken with many people. How do we cost effectively support someone through something that's 6 to 12 months or maybe even longer? It's a tough sell. So there's people are going to need to do a lot of things on their own. They're going to need to be able to self-manage. They're going to need to be able to dial intensity up and be able to change and manipulate things away from us, which is why education becomes so important. Having some regular impact, a contact like email or message, whatever it may be, is going to be important, because people are going to need motivating and support around the time frames that it takes to be able to make these changes. Tom Goom says here that if we look at this as a tendinopathy timeline, we get the diagnosis and then we help the person understand tendon pain, reduce fear, dissociate tissue damage and pain, and then consider the intrinsic variables, determine someone's current capacity, so load tolerance, and be able to get the exercise history, and then provide an individualized loading program tailored to the person, adjusting according to a pain monitoring mobile. And at 3 months, if there's no improvement, then go to the more invasive things like imaging and potentially shockwave and more invasive ideas, which Pete Malliaras will say from his experiences that 3 months is just not realistic time frame to be able to see these changes. Some people, it may be only minuscule changes in their pain sensitivity, but their strength and their functional characteristics are showing change. So we need to be able to persevere with this for 4 months, 5 months, and then being able to see and support someone around the long term that it often takes with these people. Most people are going to come to us with tendinopathy. I've got a tendinopathy now in my knee, and I'm managing it. I understand it. I know how to provoke it. I know when I've done too much and where I'm at. But this is something I've been dealing with now for 2 years. So this mindset, when we're trying to get this across to people, they've generally been dealing with these things. This is why they're seeking help, because they're not settling down. So setting the mindset around the time frame and actually what we can do and be taken out and what we can do in that period of time is super important for guiding someone through. This is, again, we're coming to the end now of the session, but an example of a load gradient to return someone to running from an Achilles tendinopathy, where, how do we structure that tail end? And this is where some of the goals, if I just make this a little bit larger. Some of the goals that we can be working with: heavy, slow resistance that we identified in the isotonics, setting people 1.5 times body weight as targets. This is a bent leg one. There's some other goals around 1.5 times in straight leg. And these are going to be dictating, hitting these markers from a strength perspective before we go on to the high and fast load. And that could be months for some people, okay? But then when someone is able to reach 1.5 times body weight, then we can start grading the reintroduction of running and hopping, when that is something that they've hopefully acceptable pain on retesting those. Then we can move to the more velocity-based isotonics, which would be, as I mentioned there, in the tempo work previously, where it's now going to be 3 seconds down, 1 second up, 3 seconds down, 1 second up, to then get to a point where they can return to track sessions. We use something like when you return to your regular training, then start off at 50%, then the following week maybe 60%, and they need to be doing 100% before they can even consider going back to. They need to be doing 100% intensity in their training before they're going back to competition. So in terms of the return to sport, as a little checklist there, end stage rehab progression has been completed all the way up to game day intensity. The load tolerance tests are all acceptable, and they pass those now, and they're stable, and we've addressed potentially the fear of returning to what maybe have caused it in the first place. So with an example for myself, my patellar tendinopathy gets flared up when I run fast down mountains. I like doing that, but there's definitely going to be a component of apprehension around me redoing that out of fear of setting this off again for another period of months. So as a healthcare professional, you might want to support me in logically grading the intensity right the way back up to running fast downhill. You'll have normalized that these flares will happen as we're working back up through the stretch shortening cycle, load management gradient, and that we've set the expectations that 6 to 12 months is what it might take. This is a little example of a tennis player that Pete Malliaras was working with, who had failed all other conservative rehabilitation around patellar tendinopathy. And this is, I'm not an expert in ultrasonography, but this is Pete's image, which illustrates a notable lesion in the patellar tendinopathy, and Pete describes how these areas here demonstrate the poor health of the tendon, and that he put him through a heavy slow resistance loading program that was, this person here had, just get my notes back here, tried everything. 12 months, Pete worked with him with heavy slow resistance 3 times a week through the phases that we've talked about here. And this was his scan at 12 months, which illustrates much more organization of the tendon, but it's still pretty messy here. But he did get back to return into play, and the time frame that it took was 12 months or more, which is what the point of this message was. It actually took 3 or 4 years to be able to change the morphology of the tendon, which does give us actually clear evidence that when we do load the tendons, that we do change the structure of it. But do we have to change the structure of it for changing symptoms? No. What was the difference in this program compared to the other failed rehab was just way more volume. And if you're not training 3 times a week and then you start doing this as a program 3 times a week, you're going to realize it's a notable commitment. But then your general health and you're starting to hit other physical activity guidelines. And a lot of people, when I put them through this rehabilitation program, in terms of the demands, will be quite surprised at how fit that they'll get, because it's a demanding, high volume approach to strength training for a long period of time. And again, that's why a lot of people will fail, because it takes effort to turn up and be able to get under a barbell, or to be able to commit to fitting it into a busy lifestyle. So here's some resources that we would use for guiding the process: outcome measures to be able to show the patient and be able to get some functional and disability checks. There's specific ones for different joints, like the Urebro, Oswestry we use in the back, but then there's specific ones in each guided session for different tendons. This is the Tasmanian Persistent Pain booklet that is really useful for handing patients, to guide them on information around what pain is, more importantly what pain isn't, to get them to be able to see that we can have changes in the nerves peripherally, we can have changes centrally. I've got video examples in here of me delivering pain neuroscience education, developing a bit more of a Socratic conversational format around some of these ideas, ultimately getting to the point where we can look at pain as a whole of life thing, not just a ultrasound scan of the tendon. That is an important part that would be going in alongside all of these load management programs. And again, to bring it back to the shoulder, seems to be much more important that we're looking at the holistic perspective of pain than even in the lower limb. Some general videos here that might be helpful that we use for getting across in a cartoon format, things like neuroplasticity and how we can change, and we change our whole life, stress, physiology, impact of that. For this booklet, you can either contact me for the PDF, because I can't attach it. These are the papers that that we will be going through for, in addition to all of these, and how we build. So from this session now, we've got an idea of the importance of how we build an exercise program, how we make it progressive, how we make it pain monitoring, how we work through phases, how we structure sensitivity, how we go through all of these, but then the specific loading of the particular tendon. We will be using Pete Maliaris for this clinical commentary here to be able to guide that. You can go and have a look at that paper and use it, but I will have videos around how I would take those guidelines to be able to come up with exercise options. Similarly for the hamstring, this one's for the elbow, Achilles and patella, rotator cuff with Jeremy Lewis, and Sancho's 4 phases in there. Okay, so this is, we're at 2 hours now. That's going to be a lecture that I hope you can review and get a lot of use from. And good luck building your programs. Contact me for any further details or discussion, and be happy to offer anything that I can and help anywhere possible. Thanks.